Good afternoon, viewers. I'm wishing you a very happy Diwali and November 14th being the World Diabetes Day. I would like to upload a video of 20 minutes depending on the problem of diabetic foot. Now, is diabetic foot a problem? What is the problem? Where is the problem and when is the problem? So this is how I have arranged my video. So let's think about it. I'm not going to spend too much time. It's a very informative video. It takes 20 minutes and in which I've concised most of the information that a diabetic requires or the bystander or the caretaker of a diabetic requires to protect the foot of a diabetic. First, diabetic foot. Is it a problem? Pain is one of the most unpleasant sensations we know, and it's difficult to accept that is actually a blessing in disguise. No one likes pain, but like all necessary evils, its role in the human body is very important. Pain is a protective sensation. It indicates there is something wrong with the body and draws our attention to it. Any activity which causes pain is potentially dangerous to health and is better avoided. Exceptions are medically administered injections. So, without pain, we would ignore all the danger signs till it's too late. Now, what is the problem? The primary problem in diabetic foot is loss of pain sensation or altered sensation due to the nerve damage called neuropathy. The patient is blissfully unaware of any acute or subtle chronic injury to the foot and continues to neglect it till the problem presents itself as an ulcer, abscess, gangrene, or deformity of the foot. Acute, that is immediate injuries like burns, pin or needle penetrations, abrasions, cut injuries while trimming nails, shoe bites, scratch marks that usually would draw immediate attention of the affected person, resulting in immediate treatment and avoidance of weight bearing till the pain subsides and wound heals, is absent in a diabetic with neuropathy. The patient usually continues to walk on the injured foot, resulting in worsening of the wound. A small wound that should have been healed with rest and treatment in a person with normal sensation becomes bigger and infected, very often needing admission, antibiotics, and surgery. The second, that is subtle or chronic injury, is something that happens very slowly, initially hidden from everyone, but later progresses so fast that it catches us off guard and is often too late. The three most common types of such injuries are 1. Callosities, 2. Ingrowing toenails, and 3. Intertrigo. Callosities. A normal person cannot stand comfortably for too long in the same position. This is because when a person stands, he exerts pressure on certain points on his feet. The skin over these points is pressed between the bones of the feet and the hard surface outside, which may be the ground if the person walks barefoot, or inner sole if the patient is wearing footwear. When the skin is pressed, the blood supply to skin stops and the uncomfortable sensation is transmitted to the brain so that the person changes position. The pressure is transferred to another point and the blood flow to the previous point is restored. This stoppage of blood flow is momentary in normal people, but in a diabetic with neuropathy, this sensation is not transmitted soon enough, resulting in formation of layers of dead hardened skin called callosities. If callosities continue to develop in the pressure point, then they become hard as stone, and the effect is similar to sticking a stone beneath the foot and walking. The soft tissue between the callosity and the bone breaks down, resulting in diabetic foot ulcerations. Usually, the patient notices these ulcers once the callosity is removed or the ulcer gets infected, releasing foul-smelling discharge or pus. Second, the ingrowing toenails. The toenails are supposed to grow straight over the edges and nail bed, but sometimes due to injuries to nail bed, improper footwear, and hereditary causes, they grow curved and push into the soft tissue of the nail or tip of the toe. This results in injuries which later become infected. Since in a normal person, the pain develops soon after the nails start pushing on the edges, they trim the nail edges. But in diabetic, since there is no sensation, the nail edges continue to grow and damage the surrounding tissue, causing infection that very often results in toe or higher amputations if neglected. The third problem is intertrigo. Intertrigo or fungal infection between toes is very common in our state. This is because of the humid climate and rains where the foot may remain wet between the toes. Prolonged excessive moisture is ideal for the growth of the fungus. These fungus slowly dissolve the skin barrier and web faces. It become portals of entry for infection causing microorganisms, resulting in abscesses which further compromise the blood supply to adjacent toes and lead to gangrene. The second problem is decreased blood supply to the feet, both at levels of big vessels called macroangiopathy and very small vessels reaching skin called microangiopathy. This is usually attributed to the high glucose levels in the blood that damage cells lining the lumen of the blood vessels called endothelium. Damage of endothelium makes it more prone to attract cholesterol deposits, forming plaques that gradually obliterate the lumen of the vessel, cutting off the blood supply. Since blood supply to tissue decreases sufficient oxygen, nutrition, and protection in the form of WBC, our soldier cells, and antibodies, our artillery, they do not reach the injury prone areas, resulting in gangrene, formation, and non healing of ulcers. The third problem is decreased immunity. High blood sugars make the white blood corpuscles lazy by affecting their cell membrane. They become slow in their responses to target and eliminate the infection causing microbes. Also, the blood with high sugar is a perfect medium for growth of microbes, providing enough and more nutrition for growth and spread of the bacteria. The fourth and rarer problem is deformity of the foot. This usually occurs due to damage and structural changes at molecular level to the nerves, bones, muscles, and tendons caused by the interaction with high blood sugar called glycosylation. This foot deformity shifts pressure from areas that are usually designed to withstand pressures to areas of foot not having enough fat pad cushioning, thereby resulting in callosities and ulcers on the weight bearing and walking areas. Also, deformed feet cannot be accommodated in normal shaped footwear, so it makes them more prone to shoe bite injuries. Now, where is the problem? Diabetes is basically raised sugar or glucose levels in the blood. So any place where the blood flows through will be affected by diabetes. This means from head to foot, diabetes takes its toll. The nervous system, the heart, the kidney, the liver, the hands, and the legs all are affected. Why foot requires special mention is because it is that part of the body that bears all the weight and is subjected to maximum physical trauma during walking. So the feet are more susceptible. Also, the nerves and vessels to the feet are longest as they are most distant from the heart and spinal cord. So, they are exposed to maximum amount of raised glucose levels. Hence, the clinical effects of diabetes can be first detected here. One of the first sensations to be lost in diabetes is vibration. So, to detect and assess the neuropathic damage, it is necessary to do a test known as VPT, a vibration perception test, every 6 months. Also, similarly, the vessels of the leg are affected, and effect can be detected in initial stages by doing an ABI test or ankle brachial index, where the blood pressure of the leg are compared to that of the arm. And when is the problem? Initially, we were under the impression that it's only after long years of diabetes that the nerves are affected. But tests are showing that neuropathy have already set in 49% of the time by the time the patient has been detected with increased sugar levels. This is called impaired glucose tolerance or IGT, even before the diabetes levels are reached. Many times, it is the clinical symptoms of neuropathy, like tingling sensation or cramps of feet, that raise suspicions and blood glucose levels are then tested. Similarly, vasculopathy or damages to the blood vessels happen early, especially in small vessels or microvasculature. These changes can easily be seen in the vessels of the retina of the eye, which may reflect the changes in the vessels of the feet. Now, what is the extent of the problem? Every 30 seconds, a limb is lost to diabetes. India will very soon be the diabetic capital of the world. At present, it is at second place with 72.96 million diabetics. 15 to 20% of these diabetics will develop ulcers on the feet, and 12% of them will end up with amputations. A person after below knee amputation has a 50% chance of having another amputation within 5 years. Once amputation is done, the workload on the heart increases from 30 to 50%, depending on whether it is below or above the knee. And this makes the patient almost 4 times more prone to heart failure. Another eye-opening statistic is that in a patient with foot ulcers, the 5-year mortality is 40%. That is, of 100 people with diabetic foot ulcers, only 60 will be alive after 5 years. And after an amputation, the mortality rate of 5 years is 45%. That is, of 100 people following amputation, 45 will die before completing 5 years. Now, what causes the problem? The main problem is raised sugar levels. As discussed earlier, raised sugar glucose levels lead to damage of nerves, blood vessels, and immunity. So there is a loss of sensation which results in formation of ulcers, followed by non-healing of the ulcer because the patient continues to walk on it, and also because there is decreased blood supply to the region. Decreased blood supply means not enough nutrition reaches the ulcer. Not only that, it also means that less white blood corpuscles and immunity agents reach the site. So the ulcer gets infected easily and also spreads easily because our immunity or defense mechanism is very weak. Once it spreads throughout the body, life is in danger. So, to save the life before the infection spreads further, the infected part, which cannot be further treated or saved by medicine, has to be removed or amputated. How to prevent the problem? This can be done by taking care of two things: good control of blood sugar levels, adequate protection of your feet. To control your sugars, you have to follow the advice of your diabetologist or physician. To protect your feet, you have to at least follow the 10 commandments. 1. Do not walk barefoot. Buy two pairs of diabetic footwear with MCR or MCP, that is microcellular rubber or microcellular polymer insoles for inside and outside. 2. Inspect the feet daily for blisters, wound, bleeding, smell, increased temperature, pressure points of feet, and edema. Use a mirror to inspect your feet if you cannot bend the knees enough to directly examine them or ask someone else. 3. Do not apply hot fomentation, cold compresses, electrical heating pads, strong balms, or pumice stone to rub the legs and feet. 4. Use correct footwear. Choose your footwear after consulting your doctor. Always wear footwear with socks with loose elastic. It is better to purchase footwear during the evenings as foot size is maximum due to evening swelling. 5. Do not walk bearing weight on an affected or ulcerated foot or after surgery on the foot. 6. Do not sit cross-legged for a long time. 7. Do not remove footwear during travel and expose your feet to a hot or cold surface. 8. Cut the nails regularly, trimmed square. If it is too thick and too deformed to cut safely by oneself, get help from a podiatrist. We have special tools to manage such nails. 9. Do not cut corns or calluses with a blade or knife. Home surgery is dangerous. Get help from a trained podiatrist who can do it for you safely using different special operative techniques. 10. Clean the feet twice daily with soap and water. Wipe the web spaces dry and apply softening agents. A few guidelines for choosing the footwear. The footwear should have a wide toe box so that the toes will not get crowded and compressed together. It should have a soft inner lining inside the straps and upper body of the footwear so the feet are not injured. A heel counter for better protection and stability of the foot. Velcro fittings on all straps and no metal buckles should be used. Adjustable straps to accommodate for the edema that sets in. Elastic bands should be avoided to prevent constriction of blood flow. The best insoles are MCP, MCR, EVA, or Plastisol. It should have a show hardness of 30. The soft leather upper body it should be the upper body should be made of soft leather with soft linings for comfort. The outsole should be rigid and tough to protect the feet from penetrating injuries and help control the muscles of the feet. It should be lightweight to give more comfort and no ankle joint pains for smooth walking. Aesthetically pleasing, it should be like any other footwear so that the patient will not hesitate to wear it outside. Now, coming to damage control, let us look into each problem graded on the basis of severity. The first problem, that is the least severe, is callosity. Even if we use proper footwear at times, the callosities occur and have to be removed, scraped, or abraded in time so that they do not form ulcers. Second, intertrigo or fungal infection between the toes. This usually happens because of increased moisture and crowding of toes, preventing air circulation. So simple steps are to keep the space between the toes dry, apply antifungal ointment, and separate the toes with a simple gauze. Ingrowing toenails and infections. Infections resulting from ingrowing toenails may initially be controlled by antibiotic, but it tends to recur because the sharp edge of the nail continues to bite into the toe. The treatment for it is to remove that part of the nail and destroy the part of the nail bed from which it originates, either using a chemical or heat. This is usually done in an operation theater after numbing the toe with injection. To cellulitis of the foot or leg. This is the earliest sign of infection of the leg. The affected part, the toe, sole, ankle, heel, or leg, shows reddish discoloration and may be associated with swelling and feels hotter than the rest of the body. It is a danger sign and should be taken seriously. Antibiotics need to be prescribed. Dressings may be needed, and most importantly, non-weight bearing is mandatory for early and complete resolution of the infection. Abscess. This is next stage where the infection has spread deeper and results in formation of collection of pus. This requires cleaning the infection surgically, sending the pus or tissue from the abscess for culture to see which organisms are growing and which antibiotics will kill them. Osteomyelitis. Sometimes the infection reaches the bone and infected pieces of bone have to be removed and sent to study them to know what microbes are causing the infection and to treat them accordingly. Necrotizing fasciitis. In this stage, the infection starts spreading rapidly in a layer below the skin. It is a surgical emergency which needs antibiotics and early surgery to control the infection. Gangrene. In this stage, the part of the foot dies but remains attached. Usually, this happens because of the lack of blood supply to the part or rapid infection. It has to be removed surgically or amputated, ideally after measures are taken to increase the blood supply to the remaining parts. Deformity. Usually, the blood supply to feet decreases in diabetes, but in some cases, paradoxically, there is an increase in blood supply because of damage to nerves controlling the blood vessels to the leg. This results in a washout of the calcium, resulting in softening of bones, small fractures, and changes in the shape of the foot. These changes are together termed the Charcot foot. In initial stages, this may be even mistaken for cellulitis and treated incorrectly with antibiotics. The treatment may include putting the foot in a plaster or in special footwear to prevent further fractures and deformity. In case of severe deformity, correction or alignment of the alignment of bones may be required using many screws and plates, followed by a lifelong commitment to wear special footwear while walking. Another type of deformity that occurs in toes is called clawing, where the toes become bent. This is due to damage to the nerves and weakening of certain group of muscles that control the toes. Special designed footwear, or in some cases, surgery may be required to prevent formation of ulcers and straighten the toes. Correction. The steps are relatively easy to understand but are very difficult to implement. 1. Control of sugars levels by adjusting the doses of insulin or hypoglycemic agents. 2. Control of infection with antibiotics and surgical removal. 3. Amputation of the dead part or that part that is too infected to be saved and is a threat to life and rest of the limb. 4. Improving the blood supply by angioplasty or bypass so that healing is improved. 5. Application of VAC or vacuum assisted closure devices that improve blood supply, continuously suck and remove the infected material and decrease the size of the wound. 6. Grafting or flap surgery uses skin or other body parts to cover the wound and heal it. 7. Designing of footwear and processes for remaining or reconstructed foot to prevent recurrence of the problems and rehabilitate the patient. Now, all said and done, after spending nearly a decade focusing on this grave problem of diabetic foot amputation that we are facing, I have realized that the solution does not lie in complicated surgical gymnastics or high-end antibiotics, but in simple measures like awareness, proper foot care, appropriate footwear, and timely intervention. I sincerely hope that you realize it too. So, wishing you a very happy Diwali, and finally signing off. Wishing you and keep stay safe, keep your feet safe. Happy Diwali. Thank you.